So this is obviously a person who doesn't need any introduction, and his face and name are known the world over. And Andrew de Beaux is here in Copenhagen. Hi, Andrew.
Hi, Ram. You're a flatterer. The glib and oily art.
Well, hardly. Well, Andrew, I've grabbed you from your extremely busy schedule today and every day, basically to poke some holes in your thinking and pick your brain, so to speak. So let's start, shall we?
I don't think you need to poke any holes. My thinking is full of holes to begin with.
You're macroporous.
Yes, I'm a large pore macroporous mesh.
But you're heavyweight, so I have to be careful as well. Well, let's go with your pet project, your baby, the peritoneal flap. I just wanted to explore the roots. How did you get into the peritoneal flap? I have read of somebody called Da Silva. Does that have any bearing on your training and how you came into this?
Not really, although we, like so many things, when you discover planes or you discover techniques, you think you've discovered them and you realize that someone has done it before you. And I can remember years ago as a trainee, I wasn't really trained by anyone in abdominal wall repair. I trained myself, so I had a fool for a teacher. And I remember getting into the retromuscular space and thinking, wow, this is actually a really cool plane. I need to write this up. Of course, Reeves and Stope had written this up decades before. So it was, to a certain extent, as myself as a teacher, it was relearning. And when it was coming to mesh repair, the early concept of using the peritoneal sac or the hernial sac, I kept both of the flaps attached to the front layer, because the physics behind the thinking was the front layer was the one that needed to be.
Around which time was it?
This would have been the late 90s.
Okay.
Yeah, late 90s as a trainee. And like the keystone of a bridge, the forces, all the vectors of the abdominal wall, you can make them into one vector, which is pushing upwards on your midline repair for a midline incisional hernia. And therefore that needed to be intact. And I was concerned that if I couldn't get it together, I'd keep both flaps on the front. So clearly the peritoneum or the posterior layer closure was a little tricky. So often there'd be a little inlay mesh into the posterior wall. There would then be your retrorectus larger mesh, and I could guarantee closure because I had both hernial sacs. But then I realized I was cutting off large amounts of the sac, and using a tissue separating mesh, so an expensive mesh as a little inlay, and I thought, well, let's actually put one flap up and one flap down. So it was a kind of a evolution. It wasn't a eureka moment. It was teaching myself the fear of not getting things closed that the technique came about.
Okay. So I have a patient in Edinburgh who has a 6 centimeters umbilical hernia, and yet another patient in north of London who has a 4 centimeter epigastric hernia. And these patients are going to see you at your office. So how typically would you deal with them in terms of, we all know the basics, let's assume you've got over all that. What is the likelihood that they end up with X procedure or Y procedure?
Yeah, I think in the old days, if you asked me that 20 years ago, I could have told you exactly what operation they were going to have, because I made that decision. And the interesting thing in the UK, and I guess around the world, is a change in hernia surgery. And we've heard that a lot at conferences in recent times of, in the end of the day, what does the patient want? Is it cosmesis, so how they look? Is it because the hernia stops them doing something? It might be they've been told to stop doing things even though they have no discomfort, or it actually now physically interrupts with what's going on. Then you have the variety of techniques that we now have. They all have their own specific benefits and their downsides, and clearly in the UK and in other countries too, the mesh issue is raising its head. And I'm seeing an increasing number of patients accepting a suture repair, accepting there's a higher recurrence rate, but they'll take their chance with a relatively easy repair, which you can often, for your epigastrics and even quite large umbilicals, do under local anaesthetic if you want. So I think the discussion with the patient helping them choose. And that's kind of what informed consent is. It's involving the patient with the benefits, the risks and alternatives to help them make their decision as to what they want. What's the best operation for them?
Many patients would say, do what you do best, doc.
Yes, that's true. And if you get given that carte blanche, so to speak, then I would say, if I was you, or if you were my mum or my daughter or whatever, depending on their age relative to me, I would then say, I think this is the best operation for you, but these are the downsides, these are the upsides. Are you happy then to proceed with that?
So would a typical 4 centimeter to 6 centimeter midline hernia, whether primary or incisional, would it get an open procedure from you, or would it go robotic or laparoscopic?
So robotically, I have very limited robotic experience at present. Again, there's a change. I went down the IPOM routes, for example. I think I did my first IPOM in 2003, 2004, and I thought this was the way ahead. Then we were the first to describe pseudo-recurrence. We didn't coin the term, that term already existed, but we published on pseudo-recurrence. And then we started to think, well, we have to improve this. Then came the mesh defect ratio, then came closure of the defect. And then we started to see the publications, including Professor Chowbe's report of relaparoscopy, relaparotomy with mesh in the abdominal cavity. We've started to see 10, 15 years down the line the complications of mesh in the abdominal cavity. And I've taken a big step back from mesh in the abdominal cavity. Preperitoneal space, better. Retrorectus, even better. But let's get mesh away from the subcutaneous compartment, away from the intra-abdominal compartment. And therefore there's been some changes in what's going. I've very, again, limited experience in ETEP, but that's an exciting way forward. And clearly the robot too is having its influence in the larger abdominal wall hernias, particularly in the elderly, short length of stay, reducing morbidity. But again, the robot is not a good cosmetic operation. It doesn't take away the skin pannus. And again, that reflects your population. We've seen the American views, we've seen the UK views, increasing obesity, large skin pannuses. Yes, you can restore the abdominal wall, but for many patients, it's what they look like. It's not their function. And therefore, that all helps you make a decision around your operation.
Right.
I still do a lot of open surgery because I can remove large chunks of skin at open surgery.
Yes. So pushing you back into that same corner, a typical 4 to 6 centimeters midline hernia, what would be the commonest operation in your hands?
I think a 4 to 6. I think, and we're talking epigastric here.
Epigastric, midline, you can
And
tell
do we
me.
have divarication or not?
Right.
I think as soon as you get divarication into the picture, suture repair in that situation largely goes out the window. It still has a role. We know that the recurrence rate might be 50%, but that still means that 50% could have a simple operation that will last them a length of time. So traditionally that would be an IPOM technique, although if you're now considering some divarication, I've started to go back to suture techniques for those, where you suture from xiphisternum to subumbilical, and it is just a suture repair as you bring the recti back together again with a barbed, non-absorbable suture. Barbed just because it's
So
easier
what's
to
your
suture.
approach? You're talking about an open midline cut down?
Laparoscopic approach.
Or laparoscopic?
Take down the falciform ligament,
Right.
stitch it, and then reattach the falciform ligament.
Okay. And you don't incise the posterior sheath like a lira?
No.
All right. So you do close the midline in those cases?
Yes. Attempting to close the midline.
All right.
And usually, for the most part, that I'm surprised as you lower the pressure down to sort of 6, 8 millimeters, sometimes less, whatever working space that you can get with the lowest pressure, how relatively easy it comes together compared to suturing on the outside.
Right. So here is a contradiction. If in these smaller hernias, where it may not matter as much, if you're closing the midline, why are you not doing that in the larger hernias and you're actually using your peritoneal flap? How does that make biomechanical sense?
Not quite sure I've got that question right. One of the interesting things, though, is about is back to the physics. And I remember Jeffrey Janis, who did engineering prior to going into medicine, giving a very interesting description of that. And the analogy is, if you get in a piece of metal, you're getting a stress fracture in the metal. What you do to stop that fracture propagating is drill a small hole at the end of the crack. And then if you're trying to repair a little hole in a long length, there's a lot of tension. So if you look at the tension lines, they will come down a bit like isobars, but then the tension lines will run round the hole and get very close together. So when the tension lines come close together, that implies a high area of tension. So then if you're closing an umbilical hernia, you're closing an area of high tension with more tension. That's why it fails. But if you were to close the midline for a small hole, but start high up to start low down, you're spreading that load over a longer length. And biomechanically, I think you can close small holes with suture, but you might have to, say you have a 3 centimeter round hole, you're actually suturing 20 centimeters, 10 above, maybe 10 below. So you're spreading the load over a longer distance. As the hernias get bigger, you don't have that luxury of length above and below the hernia. And that's perhaps why, as the holes get bigger, a suture repair by itself doesn't work.
Yes, but don't you see, and like I have seen several cases where the diastasis repair, which has been done with this kind of good intention in mind, has actually caused hernias when those sutures have worked like setons and cut holes into the midline fascia.
Yes, there is the potential that you will cause that. Interesting, in the plastic literature, they can't show any difference when they would do an abdominoplasty and a plication. They can't show any obvious difference between a slowly absorbable suture versus a permanent suture. So I guess getting around that would be the idea that maybe a slowly resorbable suture may be a better way forward, because I guess it's that shearing every time we move, it's that constant rubbing of tissue against the suture that allow it to cheese wire through. And you're absolutely right about the seton style, and that's why I'm generally anti-transfascial sutures. Because if you put enough tension on the suture because the mesh is wanting to move, because the augmentation isn't strong enough, then you'll find those sutures will cut out.
Right. And here is one of the things which has also been bothering my mind for some time. You have been dealing with pretty complex hernias since the last several years with the peritoneal flap technique. And on the other hand, we see experts presenting major data showing significant, massive number of complications like recurrences or surgical site occurrences that happen in those cases, which are very similar to yours, where the midline fascia has not been closed. So where is the disparity between these two perspectives? There has to be something which is a missing link between these two.
Yeah, I think there is, and there's so much about philosophy. It's almost religion of hernia, and we believe in our pet topics. And a lot of very eminent people have written about the psychology of belief. There's some very interesting articles on how to convince someone when facts fail. And we have that, is the earth flat, is the earth round? We have that about politics, we have that about our religion. The more we are challenged, the more we become entrenched in our views. I would have to say that the peritoneal
No, but here I'm not talking about views. I'm talking about data.
I think one of the interesting things is that the peritoneal flap doesn't have a lot of data at present. It has the enthusiasts. So there's my own work or my team's work. There's Agneta Montgomery's work from Sweden. I know that there are some advocates in India, Shafraz Beg, for example. Yignes is doing a lot in Mumbai. And I'm really excited to see that data, to see, is it a technique which you can read about, you can be lectured to, and hopefully go away and do it reliably. As compared to some of the other techniques, now I don't want to bash tar, for example. I think it has its role. I do use it in certain circumstances, but what tar allows you to do is also damage the abdominal wall. If you're not quite sure where you are, those layers are all relatively thin, and it's very easy to cut not just the cut transversus abdominis, but go a little bit squint and cut other things like internal oblique, external oblique, and suddenly end up subcutaneous. And then we are creating disasters for ourselves. And there's still a tendency that hernias are just a hole. And we see that, we see that in terms of even high quality groups like IHC, like your own AWSC, where people present their cases, say, what would you do? Sometimes they're just wanting reassurance that they are experts and they're doing the right thing. But I also get the impression that sometimes there's people who aren't hernia surgeons are wanting to know what to do, being told what to do, then saying, how do you do it? Being sent a message how to do it, and then going and doing it. If I have a patient with pancreatic cancer and you tell me I need to do a Whipple's, I won't then say, tell me how to do one and I'll do it tomorrow.
Exactly.
And we need to change that ethos. And we are in Europe slowly making changes. We have convinced the UMs. They're our licensing authority, pan-European licensing authority. They give accreditation exams in coloproctology, transplant, HPV. We have persuaded that group that abdominal wall surgery is a separate subspecialty. They've bought into that. And in 2021, this year, we have performed the first examination for the UM's abdominal wall section. So as we can get the message out that abdominal wall surgery, which includes the breadth of inguinal hernias, but I'm not saying all inguinal hernias should, for example, should be done by hernia surgeons, but I wonder all recurrent ones, perhaps all big ones, should be done by people with an interest who operate on these things regularly. And again, that reflects countries. So we know that there are some surgeons around the world who do a huge number of operations, and they do so many operations with such a big team that they can do HPB and colorectal and what have you. But for most of us, we do need to be more selective in what we do. It's not just a hole, not just a hernia. And there are many ways of doing it, and as we sort of discussed to begin with, there are risks, benefits, and alternatives. You can't be a one operation surgeon. You have to have lots of tricks in the toolbox.
Right. One final question. What do we expect to see in Andrew de Beaux in the next 1 to 5 years? Where are you going? What are you doing? What are your plans, personal or professional?
Yeah, good question. It's like all these things, COVID has been a very interesting time where you rethink what you want to achieve. And I'm not quite sure. I'm at a crossroads in my life. I spoke to my pension advisor the other day and I was talking about pension options. And halfway through the chat, he says, you're not wanting to speak to me about pensions. You're having a midlife crisis, aren't you, as to what you do with your career. I think as I take a bigger role as General Secretary of the European Hernia Society, my legacy, I'm not really looking for a legacy. I don't want to be famous, really. But I want to...
That's easy to say once you're already famous.
I want to finish my time encouraging the next generation that abdominal wall surgery is something not to be laughed at. I've been at so many conferences outside of hernia surgery and stood up and said, I'm a hernia surgeon. And I hear people saying, oh, he wasn't even good enough to be a breast surgeon. My dear old mum, when asked what kind of surgeon her son was, would say he's a hernia surgeon. But he does big ones, you know. She had to justify that he wasn't just a hernia surgeon. And we have to change that. You know, and I've said this many times, but hernias are for heroes and sheroes. This is not trivial surgery. It's quality of life surgery. And therefore what patients will accept after cancer surgery is very different than what they would expect after benign surgery. And hernia surgery or the outcomes of hernia surgery are still not good enough. Surgery is safe, but we can make it safer. And that's my plan for the next few years.
Andrew de Beaux, thank you very much.
Thank you, Ram. Pleasure to speak to you.